Good afternoon, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Improving Health Outcomes Through Health Literacy. I'm Bill Kennedy, State Social Work Director at the Department of Public Health here in Alabama, and if you have any questions about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. No partial credit will be awarded. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on February 28, 2026. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it does qualify for classroom hours. If you're watching on demand, it is considered non-classroom hours. And now, let's meet our presenter today. Ms. Brescia Gordon is the Health Literacy Specialist at the Central Alabama Neighborhood Health Initiative. Dr. Gordon, I know you have a lot of great information. Let's go ahead and get started.
Thank you. So, thank you. Today I'll be coming to you to talk about improving health outcomes through health literacy. I am, again, Brescia Gordon. I am the Health Literacy Specialist for the Central Alabama Neighborhood Health Initiative. So the objectives for the presentation today are to define the key concepts of health literacy, to highlight the impacts of health literacy on healthcare outcomes, and to discuss ways to improve patient-provider communication. So the National Action Plan to Improve Health Literacy has 7 components. The first component to this particular plan is to develop and disseminate health and safety information that is accurate, accessible, and actionable, to promote changes in the healthcare system that improve health information, communication, informed decision-making, and access to health services. The third component is to incorporate accurate, standards-based, and developmentally appropriate health and science information and curricula in child care and education through the university level. The next component is to support and expand local efforts to provide adult education, English language instruction, and culturally and linguistically appropriate health information services in the community. The next component is to build partnerships, develop guidance, and change policies, to increase basic research in the development, implementation, and evaluation of practices and interventions to improve health literacy. Lastly, to increase the dissemination and use of evidence-based health literacy practices and interventions. So let's talk about what health literacy is. Health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information to make appropriate decisions. Low health literacy is more prevalent in older adults, minority populations, people who have a low socioeconomic status, and underserved populations. So the importance of health literacy. First and foremost, it can help a client or a patient complete their paperwork. It can also help them empower them so that they can seek support. It helps them understand medical directions. It helps them navigate the health system. They can analyze the risk and the benefits. They're able to organize their health appointments. They're able to understand nutrition. It builds their confidence. And lastly, it helps them to understand how health insurance works. So some other components of health literacy. You have health promotion, disease self-management, the effective use of health services, self-efficacy, and empowerment. Health literacy helps all of these different components. When it comes to health promotion, health literacy can help organizations promote health. Also to help with disease self-management for clinical practices. It helps individuals who are dealing with whatever type of disease or health issue they're dealing with be able to manage their own health. Also with the effective use of health services. For example, many people use the emergency room instead of urgent care. Well, through health literacy, it can help individuals determine how exactly they need to best use certain types of health services. When it comes to self-efficacy, it can also help them when it comes to self-empowerment and making certain decisions. And lastly, empowerment. Again, helping individuals become empowered so that they can make good health decisions. So just a little health literacy data. People with low health literacy are more likely to report poor health. Low health literacy equals increased negative health outcomes. Plain language is the preferred type of communication, and low health literacy increased healthcare costs in the billions. So this particular pie chart is showing you health literacy in the U.S. So as you can see, the majority of individuals in the United States are considered to have intermediate health literacy. Then you have, basic, which will be 22%. Below basic is 13%, and proficient is 12%. So what this is saying is basically individuals who fall in the proficient category of health literacy represents the smallest percentage, which is 12%. So proficiency is basically defined as an individual who can perform complex and challenging literacy activities. Intermediate is defined as an individual who can perform moderately challenging literacy activities. Basic is an individual who can perform simple everyday literacy activities, and below basic is one who can perform no more than the most simple and concrete literacy activities. So again, below basic. So just some examples. So for an individual who may fall in the below basic category, an example is that being able to identify and correctly circle the date of a medical appointment on a hospital appointment slip. Basic, an example would be they can give 2 reasons that a person with no symptoms of a specific disease should be tested for that disease based on information contained in a clearly written pamphlet. Intermediate is the ability to accurately interpret and understand a prescription drug label. So again, individuals in this particular category can look at an actual drug label and understand exactly what the medication is and know exactly why they need to use it. The proficient category is an individual who can calculate an employee's share of health insurance costs for a year using a table that shows how the employee's monthly cost varies depending on income and family size. So again, this particular example would be what a person who is considered proficient is able to do. So low health literacy. So let's look at some effects of limited health literacy. So as you can see on the left, there are signs of medication literacy, and on the right, the effects of medication use. So often unable to name or describe how to use their current medications. This can decrease in adherence. So again, that's basically stating that an individual who's able to name and describe their current medications are more likely to be adherent to their medications. Have limited understanding of their medications and associated side effects. So this can be an increase in medication errors. So then you have less likely to take medication appropriately and ask questions to their pharmacist. There's a higher risk of misinterpretation during communication. So again, if you have an individual who may not be comfortable asking certain questions, let's say regarding their medications, then they're at a higher risk to, again, make mistakes when it comes to taking that medication. Yes.
Yeah, so I know my own personal position there is that oftentimes I get a medication, the doctor tells me what he wants me to take, and then I go to the pharmacist, and then I end up on like a generic brand. And so, that confusion can happen because you think your doctor tells you one thing, and then when you get to the pharmacist, you're on a different, or at least a different name of medication. So I could see where that would be very confusing.
And what I've always advised clients to do in that particular case, ask more questions, ask the pharmacist, utilize the pharmacies more. They're very much underutilized in terms of helping patients understand medications that they're taking and even reasons for it. Sometimes there are also contraindications in certain issues that a person may have. So for example, if an individual is received a prescription from their primary care provider, then that prescription may cause some issues with another medication that they may be taking from their heart doctor, especially if the primary care provider is unaware of those particular medications. So again, that's the importance of keeping up with the medication, even using the same pharmacy if possible, so that the pharmacist can at least catch situations like that. So here's some more red flags for low literacy. First and foremost, it may be an individual who has frequently missed appointments. You also may have someone who has incomplete registration forms. And this particular red flag is important because it can indicate perhaps this person is unable to read and write, which is why communication is very important when it comes to patients or clients. You also can have a person who's non-compliant with their medication. So for example, you may see them go over their medications at their appointment, and when they come back, then they have not been taking their medication. There can be a multitude of reasons for this, but again, a person who has low health literacy is, again, more likely to be non-compliant when it comes to medication adherence. You also have an individual who's unable to name their medications or even explain the purpose or the dosing. You have individuals who identifies pills by looking at them, but they're not reading them. Again, they may not be able to pronounce the word, or they may not even understand exactly what it is that they're taking. An example I like to use is that sometimes you have individuals who say, I take the blue pill for my blood pressure. I take the round white pill for my high blood pressure. Those are examples. Another red flag would be an individual who's unable to give coherent and sequential history. Then you have individuals who don't ask a lot of questions, so they ask fewer questions. Maybe not because they don't have any questions, they just may not feel comfortable enough to ask questions. And lastly is when you have someone who lacks of follow through on tests or referrals. So it's a client or a patient who you may refer to get tested or send them for further testing or referrals, and they do not attend those appointments. So again, those are just some red flags for low literacy. So patients with low health literacy, they're more likely to visit an emergency room. They tend to have more hospital stays. They are less likely to follow treatment plans, and they have higher mortality rates. So now we're getting into different strategies for health literacy. The first one would be plain language. Plain language is a form of clear writing that is easy to understand. It is to the point, and it helps improve communication. It also saves time and money. It reduces barriers in communication. Some examples of plain language are use every year instead of yearly, or you may use the term high blood pressure instead of hypertension. You may use prevention instead of prophylaxis, use by mouth instead of oral, and you may say tired instead of fatigue. So these particular visuals are just, again, different uses of plain language and showing the benefits. So I will kind of refer to the visual on the right. you have medical terms like carcinogen, intravenous, mammogram, pulmonary tumor, and verify. So as you see on the right, there are some plain language substitutes. So carcinogen is what? Cancer causing. So that would be what you would say versus the medical term. Or instead of intravenous, you would say into your vein or into your bloodstream. Instead of mammogram, you would say breast health test. Instead of pulmonary, you would say this is related to the lungs. Again, tumor, you will use growth and lump instead of the word tumor. And lastly, when it comes to verify, you would say I will check or find out. So again, these are just some more examples of plain language. Explain things clearly and in plain language. Use a teach back or show me technique to check understanding. Focus on key messages and repeat. Use patient-friendly education materials to enhance patient-provider communication. Also, speak at a slower pace and use fewer words. Use analogies, especially if you have individuals who are hard to understand. Use graphics and pictures. I find this to be very, very helpful. Also, provide information on an appropriate grade level. So again, if you have an individual who is able to read and write at a certain level, then that is the level in which you should communicate with them. Ultimately, always communicate with your clients and patients on the level in which they're able to understand. So this example is just showing you how the teach back method works. So on the left, you have the provider, and on the right, you have the patient or the client. So first and foremost, you would teach the new concept or the skill to the patient. You would have them to repeat the new learning in their own words, or they can also demonstrate the skill. This is what we refer to as teach back. You would then clarify or correct any misunderstood information. Again, they would repeat the corrected information. You would ask them, what questions do you have? And then also continue the process until concept or skill is understood. Please understand, all patients and clients are at different levels. So for some, this may take a lot longer than others, but you have to be patient when working with, again, individuals who need to understand what it is that you're trying to teach them. So in this particular technique, the health literacy principles that we're using is first, we're encouraging questions, which is what? That is empowering our patients or our clients. We're also using plain language, words in which they can understand. Lastly, limit the teaching to 3 to 5 concepts. You do not want to overburden them with too much at one time. This is just another visual of the teach back process. First, you would share the information. 2, you will confirm the understanding. 3, you will rephrase or clarify. So again, you may have to explain it in a different way until they're able to understand. And lastly, you would continue to do this until the individual is able to understand what it is that you are trying to teach them or share with them. So then we go into patient communication. So patient-centered communication is highly important for any provider. So first and foremost, at the top, you have informed and proactive patients. Then in the middle, you have improved communication. On the right, you have the healthcare system, and on the left, you have the physician with communication excellence. Then you also have just around skills, knowledge, motivation, adaptation, education. These are all of the things that's necessary to improve clinical outcomes. Patient-centered communication takes place in all facets. So in every operation or your system, things have to be created in a way in which is going to improve clinical outcomes. So when you have a breakdown in communication, a person's ability to manage their care, emotions, and disease management is impacted by the way providers communicate. Miscommunication or a breakdown in communication and patient-provider relationships can lead to negative health outcomes for a patient in a health institution.
So I got a question.
Yes.
You know, us guys, we're bad about, not asking questions, and we, try to be tough. We're not worried about our own health, those kinds of things. So if you're working with an individual that's maybe a male gender, and they're not real good at maybe talking about their health, or not good at asking questions, what are ways as a clinician you can better engage somebody that's I'm busy, I don't have time for this, or I'm kind of in a rush, but they're not really grasping what's being said. And so you talked a little bit about teaching, those teaching moments. What are some ways to really kind of get somebody to open up and ask, or better gather what they're saying?
I think first and foremost, you have to assess that individual because everybody's different. Everybody's motivations are different. For some, it may be an issue of just being uncomfortable with opening up and asking questions and being open about what's going on with them. For others, it may be that they want to open up and explain, but they don't know how to say what it is that they're feeling. And so I think as a provider, first and foremost, patience is key. You have to be patient. And that may mean that at a little at a time, each appointment, you just pull a little bit more and a little bit more. I would advise that having a heart-to-heart with that individual, letting them know that you're a human first before you are what it is that you do professionally. And sometimes that may go a long way with patients or clients. They feel more comfortable, it lets their guard down so that they don't feel defensive, and understanding that you're there to help them. Providers should also be very mindful of the tone that they use, from body language into the way in which they communicate. Sometimes it may even require, depending on, let's say you have a female provider and you're uncomfortable because you're male, then maybe that provider should bring in a male, maybe a nurse on staff, someone who works within that support system for that provider, to then talk with you and have certain conversations. So again, it just depends on the individual, but the providers have to be able to have that skill to really know what questions to ask, to figure out, okay, what exactly do I need to do to get this patient to be comfortable to open up.
And you mentioned motivation. I think literally had this conversation this week. A friend of mine said, "I wish you would talk to my brothers. Our dad passed away at a young age, and they're not willing to go get some of these tests that need to be done because for whatever reason." And so, trying to help motivate them to make good decisions, so that later in life, all of a sudden, they're not really sick or have missed some opportunities to have had some diagnostics or make some changes in their life at an earlier age when it could have been more beneficial.
Right. And I also think that that's the importance of if you have, social workers on staff, if you have other people, support staff on your team who are in a role in which they can really relate to the patients in a way in which they're comfortable to communicate with them. So I would also just say use your team. Sometimes providers tend to take a lot on themselves, but use your team.
And outreach before to get them to come in, outreach maybe to even get them to approach the physician's office so that they can, learn more about what's going on. So you talked about having pamphlets and things earlier that are easy to see. We like pictures,
Mm-hmm.
something we can look at and we say, okay, we know what that's saying, because, but as you get older in life and you have colonoscopies and prostate exams, those are just things that we're not real interested in doing, but but certainly need to have done.
Absolutely. Okay, so again, the breakdown in communication. So patients value clinicians who are first sensitive to their needs, which is what we were just discussing. They value clinicians who listen and respond carefully and appropriately. They value physicians who meet them where they are, and also who explain things in a way that they can understand. So this is just an example of communication breakdown. It just gives you different ways in which there can be a communication breakdown, and then it shows you the different functions that take place during these particular breakdowns. So then we move on to health outcomes. So first and foremost, negative health consequences occur when a breakdown in communication occurs. This can be detrimental to a patient or a client. Low quality health care and support staff can also lead to negative health outcomes. Receiving inaccurate information or having symptoms ignored can also cause poor health outcomes. Compassion goes a long way. So in this particular visual, you see we're talking about cultural awareness, cultural knowledge, cultural competence, and cultural sensitivity. So under the cultural awareness, it shows that self-compassion, universal elements of compassion, and philosophies in religion are important. Then you have cultural knowledge. Again, the cultural compassion beliefs, cultural similarities, and differences in understanding compassion. Then you have cultural competence, which influences compassionate assessment, compassionate caregiving, courage and compassion, barriers and challenges of compassion. Lastly, you have cultural sensitivity, which giving and receiving appropriate compassion, forming compassionate therapeutic relationships. All of these particular components are impacted by compassion, whether it be the provider providing compassion to the patient or whether the patient providing compassion to themselves. So then we move into cultural competency. So racial and ethnic minorities are disproportionately burdened by chronic illness. They have higher morbidity and mortality rates with chronic illness. African Americans are also more likely to be limited in physical activity, usually due to neighborhood safety and access, transportation, and chronic illness. As the U.S. becomes more diverse and people live longer, the impact of chronic illness will increase. Access to care also contributes to prevention, diagnosis, treatment, and management of chronic illnesses.
So yeah, one of the things that we noticed as we've been going through the pandemic the last couple of years is how much the chronic illnesses, folks that are obese, folks with high blood pressure, diabetes, all of those things, we saw higher mortality rates related to infectious diseases. And so one of the things that we kind of been connecting is things that we were doing prior to COVID here at the health department, such as talking about cardiovascular disease and high blood pressure and diabetes and things like that, the relationship it had with infectious disease. And certainly, any thoughts on that?
So as far as the relationship between COVID
just infectious diseases and the body and
absolutely. When you look at the pre-COVID numbers versus the post-COVID numbers, there's a difference. And there are a lot of things to take into consideration. The world practically shut down for close to a year, which for some people, it led to more sedentary behaviors. They weren't able to go out as much, not be as active, and things of that nature. So, there's this moniker of the COVID-20. which a lot of people did gain weight during that time. And then you have some people who were able to really get on like a workout regimen and things like that. They use that as coping, as a way to cope with, what was going on. But in terms of infectious diseases, as a person who's worked in infectious diseases, there was definitely some differences. So I would just share from personal experience as a person who worked in that field during that particular time. Being unable to test for HIV, for different STIs and diseases, it changed operation, having to come up with innovative ways to go out and still try to take these services to individuals. But the reality is that the numbers did change. A lot of behaviors increased during that time. So be it sexual behaviors, be it, again, going back to obesity, be it individuals eating more because they're at home all the time, working remote. Some people even lost their job, which again, that led to stressful behaviors. So a lot of times people have, they take on certain behaviors as a way to cope with their circumstance, which then leads into these chronic diseases like diabetes and obesity, and even HIV is considered to be a chronic disease now. So there are definitely, yes, COVID did impact that. But I think now numbers are starting to level out. Things have kind of gone back to normal. But there was definitely an increase in certain numbers because of COVID when it came to certain diseases.
Thanks.
You're welcome. So again, racial and ethnic minorities are less likely to have a regular doctor and health insurance. So this particular chart is just showing you the different percentages so first you have the first figure, which is the proportion of the non-elderly population who do not have a usual source of care by race and ethnicity. And as you can see in this particular group, the Latino population had a higher percentage. And the lowest percentage was white non-Latino. And so in the second particular group, you have a proportion of the non-elderly population who are uninsured by race and ethnicity. So the highest population with this one was Latino population, and then the lowest was white non-Latino. So what that is showing is that there's a higher percentage of the white population who are insured, whereas there's a higher percentage of Latino population that are not insured. So then you have older African Americans and Latinos who are more likely to have chronic conditions. So again, you have the proportion of adults aged 50 and older with chronic conditions by race and ethnicity. So we have African Americans who are leading this particular category, basically stating that African Americans aged 50 and older are more likely to have chronic conditions. The next category would be Latinos. They had the second most. Then under Latinos, we have white, and then lastly, we have Asian Americans who had the lowest rate of chronic condition, ages 50 and older. So then, yes.
With the communication barriers that we have with the Latinx community and the African American community, do we have something set up in our system to where we follow up? Like follow up after the visit?
What visit are you referring to?
Like say they come to the hospital, the emergency room, or a doctor's appointment. Because sometimes when you're dealing with Latinx and African Americans and you have them in the office, I know some of us are real comfortable, but they're not comfortable because the numbers just show that a lot of them don't have medical insurance, regular medical insurance, so they're not getting regular visits. So they're coming to the office and they're not accustomed to being in a doctor's office, and they don't know what this means that you're asking them all these questions. We're dealing with some people that they might have people that are not legal in the United States. So I'm just saying, do we have something that somebody calls them up after their visit, like 3 days later, and say, hey, just break that barrier and get real with them and really talk with them and see if maybe that they can communicate, get a deeper understanding with follow-up?
So I will say it just depends on the system, right? So when we talk about that, we're looking at hospitals, we're looking at health departments, we're also looking at private practice. And so each entity has its own system. Usually hospitals will have social workers, and now with the increase of Latino population in the United States, some organizations do have someone on staff that specifically works with that particular group. However, you're going to have some organizations that don't. That's just the unfortunate reality. And sometimes that can also play into the numbers, right? Because it doesn't mean necessarily that individuals who fall into this particular population don't have access to care. They may have access to care, but when you don't have the individuals on staff who are able to first translate, okay, who are able to advocate for those particular individuals, then that's going to play a role into adherence. It's going to play a role into everything that you mentioned. But when it comes to retention, most hospitals, most healthcare organizations do have something in place as far as following up with patient. But when it comes to including the cultural aspect to it, then some organizations honestly just don't have that. And you probably won't find a lot of nonprofit medical organizations that do, but it also depends on what area of the United States you're located. So we're here in Alabama, certain services may be more limited, whereas if you go to maybe Florida, Texas, states like that where there is a large Hispanic population, you're more likely going to have people on staff who are able to also cater to their unique needs.
And I'll just add, with the health department, we do have some programs where we do follow up. Oftentimes, or a good percent of times, it's difficult to find them. Either whether they're not answering the phone or the phone number that they gave is no longer in use, or maybe they didn't even give good information because maybe they don't want to be found for whatever reason too. So those are all struggles that we have on this side, trying to do follow-up, and it does make it difficult here in Alabama. Rural communities and communities that are just a little different or don't have the access to care that we would hope for.
And I would just also add, as a person who's worked in the healthcare system, I would just say, and of course I'm not going to name the organization, but we had a very hard time even finding someone who was bilingual. Well over a year, to even find someone. It's not that people don't exist, but they may not work in healthcare. They may not be interested in working in healthcare. And so it's a lot of limitations of individuals who are bilingual in this particular area. And so I do think that needs to change. But again, like you mentioned, Alabama specifically is out of the 62 counties, majority of the state is considered rural. So that's going to also play into that statistic. Even though in some of those counties you still have a high Hispanic population, the resources just aren't there. But that's just speaking to Alabama. All states are different. Mm-hmm. So out of 37 million adults in the U.S. who are bilingual, 48% of them do not speak English very well. Language and communication barriers can affect the quality of care received. Health service may also be impacted by the availability of translation services. Communication barriers can also lead to poor comprehension and adherence and lower quality of care. Ethnic minorities tend to report less partnership with providers in medical decisions and have lower satisfaction of care. And so I would just kind of add to this, some of that, at least speaking from the African American community, comes from a lot of distrust when it comes to the medical community. And so, again, as a person who identifies as African American and a person who's also done research on this, it is a fact, especially in the southern states, but not just southern states, but specifically in the South. There's a very large distrust when it comes to whether it was vaccinations, whether it's taking medication, whether it's going to see physicians, and even if you do, you may have individuals who are uncomfortable and they do not fully disclose. And so that's just an example of when it comes to a communication barrier. Some of it is just historical mistrust. So then we go into person-first language, which is highly important when you're working in any kind of profession dealing with the public or just working with people. So when we talk about person-first language, an example would be, so instead of saying this person is mentally ill, we would say this person is living with a mental health challenge, or you may use the diagnosis if the person prefers that. You may, instead of saying, oh, this person is crazy, insane, or disturbed, you would say the person is living with a mental health challenge again, or they're living with some type of trauma. You also have depressed and schizophrenic. You would say the person is living with depression or schizophrenia. And so these are just giving a multitude of examples. At the bottom, you see that language that feeds stereotypes. So again, we talk about mental illness. Mental illness plays a large part into stigma. And so you would say a mental health challenge or a crisis. In some cases, some people may even use behavioral health. You also have drug and alcohol abuse. So again, we would say substance use challenge or crisis. Committed suicide, you would say the person died by suicide or they were lost to suicide. And lastly, you would say failed suicide, you would just say that they attempted suicide.
Thank you for sharing that. I work with the Center for Emergency Preparedness, and we work with individuals with disabilities, our functional and access needs population. And so we talk a lot about using people first or person first language. And somebody that is in a wheelchair, maybe you would say a person who uses a wheelchair, or person first language, a person with whatever type of disability. And so those are a person that's experiencing homelessness even, right, as opposed to he's homeless or something like that. So yeah, great information. Thank you. Mm-hmm.
So just some low literacy strategies to move forward. First, to adopt a supportive and unhurried manner to minimize patient anxiety. To use a health navigator or case manager to assist with communication and coordination. Also to assess the patient's goals and to make it consistent with their goals. You may want to ensure that the patient has appropriate support or assistive technology that may be needed. Also, to record the health plan in the electronic health record. This is highly important. I would also like to go just one step further to say, in some cases, you may even want to provide the health plan to the patient. So even if it's just notes that you may take, or just some instructions or something that they can use, especially for individuals who are older or may be more vulnerable, so that they can have something to go back to. Also, to always use the teach-back method to provide a warm handoff, written or verbal report to the patient's next provider or caseworker. So some implications of low literacy. Research has shown that the elderly tend to have lower levels of literacy due to less formal education. This can also be said about racial and ethnic minorities. Low literacy can impact the patient's ability to understand prescriptions or medical instructions, health educational materials, insurance or patient forms, and how to advocate for themselves. Low literacy skills burden the healthcare system financially, which only creates a larger problem that is more difficult to resolve. Providers and staff can also become burned out, which then leads to negative attitudes, poor quality of service, and negative health outcomes. Health literacy is influenced by the language we speak, our ability to communicate clearly and listen carefully, and our age, socioeconomic status, cultural background, past experiences, cognitive abilities, and mental health. So then we move into health communication. Increase the proportion of adults whose healthcare providers involve them in decisions as much as they want it. To increase the proportion of adults whose healthcare providers check their understanding. And to decrease the proportion of adults who report poor communication with their healthcare provider. To increase the proportion of adults with limited English proficiency who say their providers explain things clearly. And it also increases the health literacy of the population. So then we move into Healthy People 2030. So the Department of Health and Human Services Healthy People Initiative helps individuals, organizations, and communities committed to improving health and well-being address public health priorities. Organizations use Healthy People goals to set their own priorities. Healthy literacy is a major theme in the Healthy People 2030 goals. So then we talk about health disparities. So health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by populations that have been disadvantaged by their social or economic status, geographic location, and environment. So then we also have to mention health equity, which is defined as the state in which everyone has a fair and just opportunity to attain their highest level of health. Social determinants of health are factors that impact health equity. So this is just showing you the different components of the social determinants of health. First, you have the education, access, and quality component. You have the economic stability. Then there's a portion of social and community context. Then you have the component of neighborhood and built environment, or sometimes people may say physical environment. And you also have healthcare access and quality. So let's talk about economic stability. Economic stability is to reduce the proportion of people living in poverty. The goal is to reduce the proportion of adolescents and young adults who aren't in school or working, to increase employment in working age people, and to increase the proportion of children living with at least one parent who works full time. And these are just some goals that are written in Healthy People 2030 in relation to the social determinants of health. Education, access, and quality. So the goals are to increase the proportion of children who are developmentally ready for school, to increase the proportion of children and adolescents who get preventive mental health care in school, to increase interprofessional prevention education and health professions training programs. Healthcare access and quality. The goals are to increase the number of community organizations that provide prevention services, to increase the proportion of people with a substance use disorder who got treatment in the past year, and to reduce the proportion of people who can't get prescription medicines when they need them. Also, to reduce the proportion of people who can't get medical care when they need it, and to increase the ability of primary care and behavioral health professionals to provide more high-quality care to patients who need it. Then we have the neighborhood and built environment. The goals are to reduce the rate of minors and young adults committing violent crimes, to increase the proportion of schools with policies and practices that promote health and safety, to reduce deaths from motor vehicle crashes, and to increase the proportion of smoke-free homes. And in the social and community context, the goals are to reduce the proportion of children with a parent or guardian who has served time in jail, and to reduce bullying of transgender students. So those particular goals are all related to health literacy because they're all a part of the Healthy People 2030 goals. Then we move into the universal precautions approach. Then we have simplifying communications with confirming comprehension for all patients. You want to make the office environment and healthcare system easier to navigate. Supporting patients' efforts to improve their health. And also, health literacy is situational. It does not discriminate. So these are just different approaches that all healthcare organizations should take. So community partners are highly important because they create sustainable, effective linkages between the clinical and community settings, which can improve patients' access to preventive and chronic care services by developing partnerships between them, the organizations that share a common goal of improving the health of people and communities in which they live.
So you're talking about community partners here, and so what are some examples of the community partners that you would want to link with to help with communication and what?
So some community partners that you may want to link with, again, you always would want to link with, especially if you're a community agency, with your local health departments, because there are always going to be some department that is able to assist. Also, the health department is really good when it comes to different types of literature. I will also just advise there's literature on the internet that different organizations can receive from different federal agencies, specifically the Department of Health and Human Services, and even some from the FDA that can be shared with patients. I will also link up with different educational institutions, perhaps higher education colleges, and utilizing them in some type of way to assist with some type of communication intervention, perhaps. I will also utilize different community agencies who may focus on health communication and doing different things to improve health communication. So when we talk about health communication, there are different aspects to it. You have the aspect of the visual aids, which again go into the literature and the brochures. You have the digital component. So I think that's also where health departments are really helpful as well. When it comes to perhaps creating some type of digital education, because so many people now are into anything digital. I think organizations should even look to hire people on staff or perhaps train certain staff members to be able to communicate, go that extra step when it comes to communicating with patients in a non-clinical way. And so I've actually played a role similar to that. And it was found to be extremely helpful because a lot of times you may have patients who are more comfortable talking with, let's say, your navigator, which is a new term, or your coordinator, or even your social worker on staff, because they feel like you're not there to give them medication. You're not there to diagnose them. You're just there to kind of be supportive and listen to them. So I think that that's also a way in which organizations can just use their staff internally to help improve health communication.
So yeah, the community health workers is another one of those words that
Right.
that we're seeing a lot more of, and trying to find individuals in the community that are maybe in these nonprofits or different gatekeepers to different
Exactly.
communities, whether it's our Latino X groups or our other groups that are in our communities, and so. As a health department, we're trying to find ways into different communities
Right.
to get our message out. I think we do a really good job of creating, like you said, pamphlets and ways and in our social media, but being able to put that information into the right group's hands and to be able to have the opportunity to share that information.
I would even go a step further to also say that, kind of when we talk about community health workers, then that really brings in that outreach component. And so one thing that's very important would be, maybe let's use the community health worker as an example. They can go into different communities where there may be certain populations that are more likely to live there, or they may target certain churches. You may have your churches where you may have your Latinx community that attend those churches, or even Asian communities. And so I think a lot of it also is just being able to figure out what that population is that you need to reach, and then putting people in place to intentionally, whether it's making sure you have literature in different languages so that there's not a barrier when it comes to different information, when it comes to different communities. So it's just putting different things into place so that you can meet everyone's needs. And that's also kind of where health equity comes in as well. So then we talk about systems, which is kind of what we're mentioning now. So when we talk about health literate systems, some of the benefits of health literate organizations are they meet the needs of the populations with a range of health literacy skills while avoiding stigmatization. Also, by providing easy access to health information and services and navigation assistance, and also by designing and distributing media content that is easy to understand and to act on. So some strategies for health literate organizations are to apply improvement methods, to improve verbal interaction, to improve written communication, to link to supportive systems, to engage patients as partners. So then we have productive interactions. So these are between patients and providers, and they involve ongoing conversations, either face-to-face or facilitated by media such as a patient portal. And then I would even just say telehealth, because that's becoming more popular. Also, during these interactions, patients and providers align their understanding of medical terms, prevention and treatment options, and care plans, and set expectations for how they will meet their outcome goals. A prepared, proactive, health literate healthcare team. These are leaders of health literate organizations who foster productive interactions throughout their organizations by building these interactions into organizational policy development, delivery systems, and patient portals. Again, a prepared, proactive health literate healthcare team will encourage community partners to engage in productive interactions with their patients. Also, by using interactions to obtain patient feedback and adapt to patients' evolving needs for understandable and actionable information. So just some takeaways. You have health literacy is important because it helps improve health outcomes. The social determinants of health, excuse me. The social determinants of health impact health literacy and health equity. Being a culturally competent provider is important in disease management. Using plain language is a way to effectively communicate with patients or clients. Using plain language is also a way, this is a typo. So I'm just going to go over some questions now, just some frequently asked questions, and then I'll answer more questions. So one question would be, what are some strategies to improve health literacy among diverse populations? First and foremost, clear and accessible communication is highly important. Again, some examples of that is to use plain language, visual aids, literature, and things of that nature. Things that are simple, not a lot of verbiage, not a lot of wording, things that are simple and to the point. Also, community engagement and education is highly important. It would be great for different organizations who have not really gotten into community, let's say outreach or community engagement as much, to really look into it. That may not be an option for private care providers, but for community organizations who may have any type of service that they offer, individuals may develop their community engagement strategies. Also, when you look at technology and digital literacy, this is going into user-friendly apps and materials, different technologies. Some people are now sending out health literacy messaging, which is something that this particular project that I work on has utilized. You also have people who may use billboards, and just different options of technology and digital literacy. Lastly, you may have culturally tailored materials and approaches, which is something that I mentioned earlier. When you're talking about diverse populations, it's important to make sure that your materials are available and also tailored to the particular populations in which you're trying to reach. It's very important that they see themselves in the materials, and your approaches should also be tailored.
You talked about culturally, but generational. We've also found that, as I get a little older, this younger generation, they talk and use words that are not as familiar to me or mean something different to me than they do to them. And I'm sure that was what my parents and my grandparents thought as well. And so thoughts on generational communication and how we say things. You talk about simple, but but words mean something, and they mean different things to different age groups.
I completely agree with that. When you talk about, I guess, in terms of age, that's also important when you're talking about the language in which you use in a lot of different communication. One thing to take into consideration is that even though statistics may show that, a lot of older adults may not have had as much formal education, that may be the case, but it also may depend on the particular race and ethnicity, right? And so that may not be applicable to all races and ethnicities. So that's where that tailored communication comes. You kind of have to know not your audience, but you have to know your patients and your clients. You may have providers who majority of their patients are older because they have really good communication skills with older patients. And the older patients go and tell their friends, who then tell their friends, and so maybe their practice becomes more catered towards older adults. Then you may have younger providers who then tend to attract individuals that are closer to their age. I think now there are so many different providers, different types of providers, from just race to age, even background. And so what it does is it gives people more options, right? They have more options of individuals in which they can go and see. But you also have organizations that cater towards older adults. And sometimes those particular organizations can work really closely with healthcare providers or any organization that provides health care, so that they can make sure that they meet the needs of older adults. Make sure that they, even with visual aids, because you may have technology and you may have a lot of older adults that's just not into that. So sending out that message through text may not work for them. So if you have patients who prefer to have something physical in their hand, then you need to make sure that you have things available so that when they come in, they're able to take it. So it depends on the provider really knowing their clientele. But organizations also have to do a good job at not just making sure that they have information to be tailored towards ethnicity, but also age. Because you want to have certain things, especially for the younger age groups. There, a lot of things out there now for them. And so a lot of people are going more technical and digital with them. But you may not want to do that maybe with your group that is, let's say, 60 and up. So the organization and the provider has to know who they're working with.
And that's some of the things that we've been doing with public health. We've been adding QR codes to different things because this younger generation, they don't want, piece of paper, but, us old school folks, we want something in our hand that we can take back and that we can look at later. and the younger generation's looking back at it later too, but they're looking at it on their phone, and they're much more going to use the phone instead of the piece of paper or something like that.
Right.
And so adding that has been very helpful. It takes you to the website, and then that's information that they can use later. It also cuts down on printing.
Yeah.
But if you're working with an older population, a phone's to use to call somebody.
Right. And you still don't want to have too much information on whatever your literature is, even for, let's say, older adults, because if it's too much and the font is too small, you have to take all of those things into consideration.
Yeah, I would just say that, not to be so rigid, not that this is a one size fits all, this is how we've always done it, this is how we're going to do it. If you really want to approach and have a varied patient population, you've got to meet them where they are and offer it in a variety of ways.
And she talked earlier about follow-up, in some of the things that we do. Some people want a letter, some people want an email, some people want a text, some people want, other ways for communication. And so, no, it's not one size fits all. And oftentimes it's generational because that's what we were, accustomed to. My kids, they don't call each other anymore. They text.
Right.
I'm like, well, how about just calling them? And let's just answer all these questions at one time. No, we don't do that. We just text. I'm like, okay.
Right.
But, and they're, if you want me, send me a text message. Well, I'm still old school. Call me, or send me an email, something like that. So lots of different ways to send information and to follow up. But then, one of the other things in Alabama, we struggle at times in places with access to internet access or having computers and things like that. So it just depends on where you are in those rural communities, what's available. And
That's an interesting point, because I can't think of a provider that's ever asked me, how would you like to be communicated with? If they tell me this is how we communicate, this is our system, rather than kind of giving me the option of, what would work best. So I never thought about providers kind of meeting me where I am versus me having to adapt to that provider system.
Right. There are different approaches. So that's why it's kind of sometimes you have to take into context what approach. So if we're talking about a healthcare organization, like an agency, that's different But when we're talking about a provider, a medical provider, then usually correct. You know, it's not really optional to the patient. They kind of create or their own system for their practice. And so, I mean, sometimes they may take some things into consideration if you have patients who say, well, why, you should do this, you know, or, and some providers are really good by listening and hearing what they're saying and putting things into practice. But then you have some who, this is the way they do it and that's the way that they would prefer to do it. So it really depends.
And, you know, there's some great YouTube videos out there, some great TikToks and Instagram type stuff, those little shorts that with information that's specific to something that's going on that can be shared. And so a younger generation is going to look at that a little better than maybe they would reading through something.
Absolutely. Another question is, how can healthcare providers communicate effectively with patients with varying levels of health literacy? First, again, they can use plain language. They can assess the understanding of the individual because everyone's level of understanding is different. They can also provide visual aids, respect cultural differences. So again, making sure that you have visual aids, literature, even someone perhaps on staff who's able to communicate with different cultures, and also to encourage active participation.
You know, one of the things that I've heard often enough anyway, is that my healthcare provider, I didn't feel like they were listening to me. I didn't feel like they heard what I was saying. And I've heard that in multiple settings, whether it was with our HIV population, LGBTQ group that said that they were not being heard. I've heard it with women who've gone in our women and children programs that said, I just didn't feel like they were listening to me or heard what I had to say. And if they're not going to respect me, or if they're not going to listen to what, I'm not going back. You know, they've lost respect for that healthcare provider in what they have to say. And it may be great information that you need to hear, but if you don't feel like you've been seen or you haven't been heard, then that's it puts up an immediate wall.
Absolutely. Providers have to make sure that they are respectful. I've heard all kinds of stories from some providers perhaps walking out on patients while the patient is still talking or expressing the concern that they may have. And I think, and sometimes it may be a level of cultural competence, right? Because it just depends on where you go. Providers there's no cookie cutter way when it comes to any of that. And so ultimately that's where that compassion comes in. Again, being patient, because as a provider, you may have a certain understanding, right, of what's going on with this patient. But the patient may not be on the same page. They may not agree. They may feel like, no, this is what's happening. And so it takes a provider to be able to be patient, to be compassionate, again, to have a certain level of cultural competency or cultural humility, to be able to try to understand where that person is coming from.
And then technology, you know, technology is awesome. It helps you get paid because you got to be able to document what you've done and then be able to send that in to bill. But not oftentimes, but it can be that you're too busy checking boxes as opposed to really listening. And so they see you looking at your iPad or your computer or whatever, as opposed to just talking. And so that's one of the things in case management, social work, that over the years, let's have a conversation and try to ask the questions that you need to get answered, and then go back and maybe pick up anything you might have missed. And
that goes into the rapport and the trust, right? Because it's important for any provider, again, or even if you work in social work or counseling or whatever, you have to develop trust with your client or your patient. If you don't have that trust, they're not going to open up, they're not going to be compliant. It's going to be very difficult to develop that relationship with them. So the client or the patient has to feel comfortable with their provider or whomever, especially when they're opening up or dealing with their health. It's very personal, that's very vulnerable. And so a lot of people have a very difficult time at being open and vulnerable when it comes to whatever it is that they're dealing with.
I like how you phrase it, there's an active participation. That I never really thought about it that way, that it doesn't just need to be, I'm going to tell you what's wrong with me and then you're going to tell me how to fix it, and we're not actively exchanging ideas. And like you were saying, like they've got the iPad, you know, they're doing their job, but you don't feel like they're actively participating in the conversation with you. And I kind of, earlier you mentioned that the providers could be a teacher. And that was kind of a light bulb moment for me. Like I'd never really thought of myself getting an education when I'm with a provider. And it's like, oh, I should look at it that way and really see them as a teacher.
And if you feel like you're being rushed, you're not going to ask those questions. They're just trying to, you know, they're in a hurry. I'm going to be respectful of the doctor's time. I know he's very busy or she's very busy. And so, you know, I know that I try to go with questions. I've got some things that I want to ask, and then I try to get those answered. But you know, if I get new information that I'm not prepared for,
Right.
then that becomes, you know, a barrier for me. I don't know how to ask that, or I don't want to waste his time or her time, you know.
And that's really a struggle with patients that deal with health literacy issues, that they don't feel empowered to ask those questions. Like you work in the health field, so if you struggle with, oh, I don't really know what to say now, just imagine someone who doesn't come from a
Sure,
healthcare
yeah.
background. So we need to be able to empower them to know, wait a minute, I didn't understand that, say it again. And that's because if the providers aren't going to stop and ask questions, we've got to empower the patients to ask the questions.
Absolutely.
And I know that when I've gone with my mother when she was dealing with some major health issues, that she had ALS, and so I would go with her because this is just so big.
Words.
And it's big on her. I mean, she's dealing with this major diagnosis. And so being able to, once we got outside, say, well, Mom, this is what I heard. And this is what I heard them say. And so, you know, not everybody has somebody that can go with them or somebody that they trust to go with them, but sometimes it's good to have somebody that can go with you also and help with that.
That's a really good point, and that's actually something that I stress when I do talk about health literacy is perhaps taking someone with you, or even, you know, you have some people who are very organized when it comes to their healthcare appointments and making sure that they try to be as compliant as possible. But then you have some people who don't have that, especially when you're dealing with individuals who may be older and they're dealing with so many other things. So if in that particular case, it's very helpful to have someone attend those appointments because that just has one more person to say, okay, I understand the directions that this person needs to follow when they're home. And so it's just one more person to help make sure that they're being adherent to whatever the instructions are. But again, that plays into health literacy as well.
It may not be that I don't understand it. I've just got the weight of this diagnosis, whether it's cancer, whether it's, you know, some major medical condition that's going on here. And so, you know, I'm just trying to get through the day. Mm-hmm. And so I need somebody there to kind of advocate and to listen and to ask those questions so that when I walk out the door, okay, I can go and do what I need to do to get better.
Right. So another question is, how can healthcare professionals develop cultural competency skills? First, they can look into cultural awareness and self-reflection. That's highly important for a healthcare professional. It is not uncommon for individuals to have some type of bias. Most of us have some type of bias, or even preconceived notion or belief, or just something that we feel inside when it comes to different cultures. However, that's when the self-reflection comes in and the awareness, learning about different cultures, being able to, when you feel like, okay, I'm being biased right now, to kind of check yourself in your own thinking, and to make sure that you are being aware of your feelings, and your actions and your behaviors, so that you are a culturally competent provider. Also goes into education and training. There are so many cultural competency trainings, even just education. And it can also mean to get your staff trained as well in working with different people from different cultures. Because what happens is when you work with people who come from different cultures and backgrounds, they may have different traditions, different norms, values, different beliefs. And so you may be offended by certain things, or they may be offended, and the intention is not offensive. But when you're not educated about different ethnicities and just cultural backgrounds, it can create issues. Also, cross-cultural communication skills, so being able to communicate with people of different cultures, or at least having someone on your staff who's able to translate if necessary. Also, cultural humility and respect. It's very important to be respectful to other people and their cultural norms and values. Again, from it may be different things that they wear, from just a multitude of different things. And so it should not be looked at in a negative way. There should be a respect there when it comes to that. And again, cultural humility, right? Also, engagement with diverse communities. So just even learning about communities, especially when you work in certain fields, maybe it would be helpful to go around, maybe go to different churches or different events or things like that, to be able to just learn more about the different cultures. And that will also help when it comes to being more comfortable in working with people from different backgrounds. Lastly, integration into your clinical practice. So all of these things you want to integrate into your clinical practice. For example, if the provider, let's say, goes and takes a cultural competency training or cultural humility training, so should their staff. Because a patient may work with their staff more so and spend more time with maybe their staff than just the provider. You want to make sure everyone on the team is able to be culturally competent. So another question is, what are some cultural barriers to healthcare access and utilization? So we have language barriers, which is kind of something we just mentioned. Also, cultural beliefs and practices. This can also play a role in access and utilization. Again, someone asked a question earlier about perhaps you may be working with patients who may be immigrants, they may not have insurance, things of that nature. And so all of those things can create a barrier to access when it comes to being uninsured. Also, religious and spiritual beliefs. So it's not just cultural and ethnic backgrounds. People also have different religious and spiritual beliefs as well that can play a role in their health care. So it's very important for organizations to be respectful. Also, you have health literacy and education. So again, this can also create a barrier to access and utilization when you have organizations that are not health literate. Also, when you talk about stigma and discrimination, so for example, you may have LGBTQ plus individuals who may go to a doctor's office and they're stigmatized or discriminated against because of their their sexuality. And so at the end of the day, it's not for the healthcare provider or organization to judge anyone. Lastly, you have family and community dynamics. Also, these things also do play a role in the barriers to healthcare access and utilization. You may have some families that may not believe in going to the doctor, or they may not have transportation. They may not have the ability to go to the doctor. It can just be a multitude of reasons and things that can play a role into healthcare access.
You talked a little bit about stigma and discrimination, and here in the South, we're all from often from small towns, rural areas, and so we all sort of look alike. We all dress alike to some extent, and so when somebody from the outside comes in, folks know when somebody's in town that's not from here, or it's not from a community. And can you talk a little more about rural Alabama and small town Alabama and stigma and even discrimination?
So, there's no secret that Alabama has always been known to play a major role in race relations in the United States. And so even though we're in 2024, that's still kind of one of our, I don't want to call it a stereotype, but when you mention Alabama outside of Alabama, that's always something that people bring up, right? And so, of course, if you're from here, you live here, regardless of your race, us Alabamians understand Alabama, right? And so, and that's regardless of whatever your race may be. And so, but it does play a role in stigma. Being from the South plays a role in stigma. And even though you may not even live in a rural area, you may happen to have grown up in the city, people still look at it as being a rural area. It's a rural state. And so they call us country. And so country can be used in a negative way. It can be very stigmatizing. But it can also be, it's like, okay, I'm from the country, I'm from a rural area, and so it's okay. And so that's just an example of some of the stigma and discrimination that comes from just being from the South, but even just being from Alabama. But when you talk about rural Alabama, our rural areas in Alabama aren't the same, right? So, you have North Alabama, Central, South. It's a completely different environment. Most of the customs and beliefs are very similar throughout the state, but some of the things that people do, our value system tends to be very similar. Whether you grew up in Birmingham, whether you grew up in a small country town, but ultimately, that also plays a role in healthcare, because then what you have to look into is there's not really many healthcare facilities or providers in rural areas, right? So what happens is it creates an issue to access to care, because there's also a lot of poverty throughout the state of Alabama, specifically in rural areas, not all, but in many. And so a lot of times when you really look at economics, most of the money is going to be in the larger cities. And maybe even some counties surrounding the larger cities. But when you really get into the meat of the really true rural areas in the state of Alabama, there's a lot of poverty there. And that crosses all racial lines, whether you're black, white, it doesn't matter, right? So that plays a role in education, it plays a role in opportunity, and also health. And so a lot of times too, those individuals are dealing with a lot of chronic illness, chronic diseases, even infectious diseases in some particular case, because they're kind of secluded, they're isolated. So they take you sometimes in those areas, it's a completely different belief system from when you come into, let's say, a city dynamic then people tend to be a little bit more open-minded, a little bit more flexible. And so those are just some examples of the difference between rural Alabama and more metropolitan areas in the state of Alabama. But even when you go to the northern cities in Alabama, they're very different from the southern part of the state. So it just depends. It depends on what part you're from. But rural Alabama is no different from rural Mississippi, rural Georgia. It's the South. And throughout the South, like you mentioned, you can tell when people come from different areas.
You ain't from around here.
Yeah, the belief system, not just the way people speak, but just the way they carry themselves is very different. And being a person who went to college and my roommate was from California, you know, we had a lot of struggles because here I am, a girl who's grown up in Alabama, and here I am rooming with someone who grew up in California. It was a complete culture shock for both of us. And so that's just an example, is that, you know, things are just different. Your beliefs are different. But when people come to the South, they love it.
And we're seeing more and more folks move to the South
Right.
because of job opportunities and because of the weather and things of that nature. And so we're seeing or individuals that are coming from other countries that are here for work as well. And so, you know, Alabama is making some changes for sure.
Absolutely. So another frequently asked question is, what role do social determinants play in shaping health behaviors and access to preventive care? So you have the socioeconomic status. So the lower socioeconomic status is associated with limited access, which again is kind of what we just mentioned with maybe say high poverty areas. You also have education. You have employment and working conditions. Also, neighborhood and physical environment plays a major role in health behavior and access to preventive care, and also access to healthcare services. How can we reduce health disparities in healthcare systems and communities? We can look into changing our health equity policies and legislation, look into becoming more or providing more culturally competent care, addressing social determinants of health, to access to healthcare services, to make sure that there is access to healthcare services. Also to provide health literacy and education, and community empowerment and engagement. So it's very, again, important for communities to mobilize and become more empowered when it comes to healthcare. One example I can share would be with the Central Alabama Neighborhood Health Initiative, which is the project that I am currently through the city of Montgomery. This is an example of how the Department of Department of Health and Human Services really wanted to target municipalities and getting them more involved in health education and health literacy. And so this particular project is an example of community empowerment and engagement. What are some common barriers to effective health communication? So some barriers, again, are language and literacy, cultural differences, limited access to information, health literacy, misinformation, and stigma and discrimination. How can healthcare providers tailor communication strategies to meet the needs of diverse populations? They can provide cultural competency training. They can begin to use plain language, utilize interpretation services, use visual aids and multimedia, respect cultural differences, and address that health disparities do exist. Thank you again. So for more information on health literacy, please visit www.cdc.gov/healthliteracy/learn, or you can contact me directly at 334-669-6911, or you can email me at bresciaarrington@gmail.com or bgordon@trentumstate.edu.
Thank you. This concludes our program for today. I want to thank Dr. Gordon again for being here. I want to thank you for watching. I also want to remind everyone that while content may continue to be relevant, CE credit will only be awarded for 2 years. And I misspoke this earlier. It expires February 28th of 2026. And so, again, thank you for being here. You can always refer back to the training and the resources at any time on demand. I hope you have a great day. And again, thank you, Dr. Gordon.